in this field. We count on each of you to respect the allotted time. As you know, in Francophone West Africa, women continue to die each day from preventable causes of death. Here are a few numbers as a reminder. Despite the progress made under the MDGs, the ratio of maternal mortality is still among the highest in the world, and it averages about 347 maternal deaths per 100,000 live births in 2021. We are still very far from the expected 70 maternal deaths per 100,000 live births in 2030. That was what was established by the SDGs. At least 27 out of every 1,000 newborns do not survive their first 28 days of life. The current rate is at 1.5%, which is far from the 7% needed in order to reach our goal of 12 in 2030. At least 72 out of every 1,000 children are at risk of not seeing their 5th birthday, and the current average annual rate of reduction of 3% falls far short of the 10% required to reach our target of 25 by 2030. And ladies and gentlemen, only 43% of women have their family planning needs met. 1 in 2 of these women is postpartum. Family planning, particularly in the postpartum period, is a high-impact intervention that can contribute to a 30% reduction in maternal mortality. Integration gives us the opportunity to optimize the care and services offered and to cover more targets by pooling our resources and means. Postpartum family planning integrated with MNCH and nutrition, best practices, and lessons learned in West Africa is the theme that we're going to discuss for the next 90 minutes. To introduce the subject, we have very important people who have a lot of experience and a lot of knowledge. They are Dr. Trifoni Nkurunziza, who is the team lead for reproductive maternal health and aging. She works at the WHO regional office, and she is also chair of the community of practice. We have Nandita Tate, who is the head of the IBP network, and Dr. Alan Damiba, who is an expert in FP at USAID in West Africa with over 30 years of experience. Without further ado, I will ask Dr. Trifoni to take the floor for some introductory remarks. Trifoni? Thank you so much, Yves, and thank you, Professor Sepu, for being our moderators today. Dear participants, colleagues, everyone who is working to improve women's health in Africa, it is an honor on behalf of the community of practice that is working to accelerate integration of postpartum family planning with the health services for MNCH and nutrition. So we know that our participants are going to be carefully listening to this webinar, and hopefully we'll learn more about best practices and the experiences that we have already had working in integration of PPFP with the MNCH and nutrition. We are working on integration in Africa, but we're also going to talk about promoting best practices at the regional and international levels. So first, we will have some different speakers who will contribute to the discussion. We would also like to share the best ideas so that we can scale up this integration. And now I would like to hand the floor back to Dr. Yves to introduce our next speaker, and we will see each other later in the webinar. Thank you very much for this session. Thank you very much, Madam Chair. Thank you for these introductory remarks. Next, I will be inviting Nandita to take the floor for some introductory remarks of her own. Thank you very much. Thank you, Dr. Yves. Welcome, everyone. My name is Nandita Tate. I am based at the WHO in Geneva, where I am the director of the IBP network. Once again, thank you very much for giving me the opportunity to speak today. As you know, the IBP network is a consortium of NGOs and CSOs that are dedicated to supporting the use and spread of guidelines in family planning practices and for sexual and reproductive health. Within this work, we create inclusive spaces to enable our partners to share the lessons learned, to talk about what works and what doesn't work, everything in between. This webinar is the webinar given by the regional COP, and it was organized at the ICFP conference in Thailand. And it was colleagues at Knowledge SUCCESS, like Aïssatou Troyer and others, who recognized the importance of creating a Francophone COP that was targeted on postpartum family planning integrated with MNCH and nutrition in West Africa. So we decided together to support this very important work of the COP. So we are very excited to see this COP be implemented, and we will remain committed. We will stay by their side. Thank you once again, and I wish you an excellent meeting today. Thank you.
Thank you, Nandita. And thank you also for reminding us of how this community of practice was born. After Nandita, I would like to give the floor to Alain. Hello, everyone. I am happy to represent our sub-region. I am based in Accra, and we are very active in all the activities carried out by the community of practice. We have carried out several studies and polls on health, and we are finally seeing some results. And I think this is a great opportunity for us all to be able to optimize what is currently being done in prenatal care and delivery care, also help with family planning and other health services. USAID works with a project that will that will finish this year, and we've just drafted a new program for 5 years to continue our work. So I wanted to announce it officially today, a first draft of this project. And a new draft of this project is available on grants.gov if you want to read it. It is currently in the process of bidding. So we are trying to continue our agenda with you to promote our goals. Thank you and have a great afternoon, everyone. Thank you, Alain. I think we've all heard you. And I would like to remind everyone that integration helps us close those gaps and also catch up on missed opportunities. I would like now to start with our series of 4 presentations. The first presentation will be carried out by Dr. Pierre Carrillo. He is the focal point for integrated health services in 4 countries in West Africa for the WHO, and he's based in Ouagadougou. He has many years of experience, and he will be talking to us about integrated people-centered care in the region. Pierre, you have 10 minutes for your presentation. Thank you.
Dr. Pierre Claver.
Pierre, Dr. Pierre Claver Carrillo, you have the floor. If you can hear us. You need to open your mic, Dr. Carrillo. Okay, we can hear you now. And if you can please start your presentation. Presentation mode. Thank you. You already have 1 less minute, Dr. Carrillo. Thank you. So this is the structure of my presentation here. On the left, first of all, I would like to start with the definition of healthcare from the WHO, and then we will move on to the world situation in terms of access to care and the quality of care. Is this any better? Can you go back to presentation mode, doctor, please?
Est-ce que c'est mieux? Est-ce que c'est mieux?
Is this any better? Not yet. Can you click on slideshow, Pierre? Yes, Chilanga is helping me, but I will need to start because time is running out.
Allez-y, défilez, moi je vais parler. Allez-y.
Donc, libérez alors la main pour que Alison puisse.
Alors, je vais libérer la main.
Voilà.
C'est parti.
OK, parfait.
On peut aller à la slide qui suit. Ah, ça, c'est le sommaire. La slide.
Voilà.
Here you see the summary of my presentation, the structure, but let's go to the next slide. Thank you. About 3.5 billion people in the world do not receive the health care they need. Up to 40% of healthcare spending is lost due to inefficiencies, particularly in Africa and South America. And each year we see 421 million hospitalizations, of which 1 out of 10 patients suffer harm related to care. Only 20% of primary healthcare agents recognize that the reference and counter-reference system is operational in the Americas. So this system very often is not operational. And also about 45% of people feel like they are not taken into account sufficiently in decision-making regarding their health. We also see a projected shortfall of 18 million health workers to achieve and maintain the universal health coverage. So all of this to tell you that the health systems very often are not very well prepared to offer the care they need to offer to the population. Can you hear me? Yes, I think you can hear me. Okay, let's continue.
Next slide. Okay. Donc ici, c'est pour définir ce que nous entendons officiellement.
This slide is the definition of the WHO of integrated people-centered care. It is about making sure that the patients have a continuum of care with prevention, curative, rehabilitation, and all of this care has to be coordinated across several levels and sites, and also respecting the different stages of life from birth to death. This healthcare approach is based on the fact that the needs of people have to be satisfied, but also the needs of communities. We need to have reliable health systems that is organized around the needs of people instead of treating diseases in an individual way. Of course,
Nous avons un programme axé sur tel type de soins. Alors que dans les soins de santé,
or that type of care, but we also have to integrate care more globally and make sure that the person is at the center and not a disease at the center.
Dia suivant, next slide. OK. Pourquoi cette approche des soins intégrés centrés sur la personne est
Why is the integrated people-centered care approach necessary? First of all, it is about having equity in access, but also offering safe, effective care that is provided at the right time and that answers the needs, the overall needs of the person, but also follows the highest standards.
En 2023, c'est pas pareil, même s'il y a des techniques qui n'ont pas changé, mais en tout cas, on doit avoir une
We
évolution dans les connaissances qui permettent
need to continue learning about what are the best practices of the time and keep up with those practices and make sure things are changing in the right direction. We also need to increase the efficiency of care and have a more resilient system.
Next slide, please. Alors, très rapidement dit, il s'agit ici de comment l'OMS a cheminé.
This slide shows you how the WHO put in place this approach. First, in 2016, there were calls from member states and stakeholders to address the challenges facing health systems around the world. This was followed by the adoption of a resolution that adopted the global strategy of the WHO on integrated people-centered care. Then we had the 2018 Astana Declaration that placed people at the center of care.
Next slide. Alors, next slide. Alors, pour mettre en œuvre les soins de santé intégrés centrés sur la personne,
To implement this approach of people-centered care, we have 5 strategies, 20 strategic approaches, and 58 policy options and interventions. You see the graph on the right that shows you how we do this. At the center, we need to create an enabling environment. We also need to coordinate services within and across sectors. We need to empower and engage people, strengthen governance and accountability, and reorient the model of care. And of course, all of this is at the center of what you do every day.
Next slide. Next. We move. Okay.
On the left, you can see our strategic approaches, and on the right, the policy options and interventions. What's interesting is to see how all of this comes together. First of all, we try to empower individuals and families. We help the most marginalized and underserved. We do it by training health workers, improving health education, also engaging with civil society, having peer support groups and patient experts groups. We, of course, focus on the most underserved and marginalized people.
Next. OK. Maintenant, il faut, pour le faire, définir les priorités des services en
To do so, we have to define care priorities according to each stage of life. So we are looking at the continuum of life from the beginning to the end. We are taking into account prevention also to prevent diseases, and we have systems based on primary health care. Primary health care is available at the first point of contact, and the goal is to integrate more services at the primary health care level. We also need to have services that are sensitive to gender, culture, and age. This is absolutely essential. We also need to have a risk stratification in the population. To do so, we look at the disease burden. We do not have the same approach whether we are working in a rural area or an urban area, for example. So we have a targeted approach on specific problems depending on the location. We also set up teams that are able to deliver primary care in a multidisciplinary way. And we are enabling shared medical records. This is very useful because any doctor can very quickly see the history of the patient, his medicine, and so on.
So here I'm giving you an example. Many of you, I'm sure, have heard about what's happening in the DRC. There is a Panzi hospital. There is a person-centered model of care developed for survivors of gender-based violence. And in this center, there is a one-stop shop where a woman can get all of the different services and care that she needs. This was the entry point for integrating all of the services in this particular situation. So this is a very poignant example, I think, of successful integration. Next slide. How much time do I have left? 2 minutes? Does that work? Yes, 2 minutes max. Otherwise, you'll go over time. So some challenges to implementation of integrated people-centered healthcare in Africa. We all know that there has been some fragility in the health service offering. Sometimes we have issues with fragmentation, verticalization, low integration, absence of leadership, the positioning of donors, and poor coordination of partners. Next slide, please. And I believe this is the last one. So some of the key messages would be the integration in service delivery requires investment in HR, in guidelines, in engagement and capacities. The effective implementation of an operational framework for primary healthcare and the IPCHS must be done together. An integration approach in service delivery in order to create a culture of accountability. So we need to implement care centers, one-stop care centers. We need to also integrate continuous monitoring of its effectiveness. We do work of MNE, and we also need realistic documentation, corrections, and readjustment measures based on evidence. So thank you very much for listening to my presentation. I will now hand you back the floor. Thank you very much, Dr. Jhpiego, for introducing us to this very important theme. We could spend 2 hours talking about this. Thank you very much for talking about the integrated people-centered health services and looking at it in the general plans. You have given us an idea of the challenge before us. And we would ask our participants to send their questions in the chat, and we will have time later to respond to them. So we can move into our next 2 presentations, and then after those presentations, we will have time for Q&A and discussion. So now we're going to focus on 2 country experiences that focus on the fundamentals of succeeding in scaled up integration, as well as information on indicators so that we can track progress and ensure accountability. For this, we have Dr. Nutano, who is the coordinator and director of mother and child health in Côte d'Ivoire with over 27 years of experience. He's going to talk to us about information systems as a fundamental foundation for scaling up integration. Then we will have Dr. Amadou Issa Amadou, a OB-GYN who is an assistant at the science school at University of Maradi in Niger. Also a director for building skills, and Dr. Isabelle Bikaba, who is the former director of Health and Family in Burkina Faso and is the technical advisor for knowledge management of the INSPIRE initiative in Francophone West Africa with more than 24 years of experience. Both are going to talk to us about a reference guide for capacity building and training frontline workers. So we will move into these 2 presentations of 10 minutes each before we move into discussion. Dr. Tano, you have the floor for 10 minutes. Hello, everyone. We are going to talk about information systems. Next slide, please. So this is the outline of my presentation. I don't think there's anything too complex here, so let's move into the presentation. So I'd like to point out that in Côte d'Ivoire, service integration started in 2019 in one of our larger districts, Anibiré-Krou. And we started working with different people, and we looked at the way to integrate these care and how we could use information systems. In Côte d'Ivoire, integrated management systems is a way to collect, process, analyze, and disseminate health information that is necessary for decision-making. We also have the SNIS that relies on primary connection tools. And here we can see one of the management tools that is used for prenatal consultations. And then we have all of the different elements that are included in the different registries. We have the consultation registries, and we have found that these are very effective tools. Next slide. So this is an example of a monthly report. So I wanted to just show you an example of one of the reports that we fill out each month. Can we go back to the previous slide?
C'est bon, ça suit?
Can you hear us?
Ça suit?
Pardon, Dr. Tano, vous cherchez quel diapo?
Dr. Tano, what slide are you looking for?
Dr. Tano?
Dr. Tano? So I think we have some technical problems that we're dealing with. So we work with contact people at the different hospitals to fill out these reports. Next slide. So we can explain a bit better when we're looking at this slide here. We have the information that goes into the database, DHIS2. Next slide. I think you skipped one. So I just want to give you the information for the DHIS2. Next slide. Next. So here we can see that we have 17 indicators, and we're going to share these indicators with you afterwards, but these are the important indicators that integrate all of the services into MNCH, as well as pre- and postnatal consultations, and everything that is involved in service integration. All of this is done at the same time as the implementation of tools and databases. Next slide. So what have we achieved? We have achieved the consideration of integration items in all primary collection tools across the country. We have also integrated all of these indicators into the data dictionary. We have looked at these indicators to measure the provision of integrated services, and we have also configured our DHIS2. So this is something that is done every 2 years, and we have updated all of our data. Next slide. So this is an example of a report. So here you can see we have everything about the number of women, pregnant women who are seen in prenatal consultation, those who came for counseling in postpartum. And we wanted to show the number of women that have not only received counseling, but also other services that were integrated. We also have the number of infants who were seen as well in consultation. So we've tried to look at all of the different elements. Next slide. So when we're looking at lessons learned, we have the integration across the health system. This is one of the pillars of institutionalizing integration. We are also committed to accelerating the scaling up of PHC integration to the entire health system in order to improve care and reduce maternal and infant mortality, which are still and always above an acceptable threshold. So what do we need to do? In Côte d'Ivoire, we need to gradually train providers across the country on service integration data collection. We're going to work at a district level in order to develop a quality system for collecting and processing integration indicators. And then we will collect data on integrated service delivery across the country and at the regional and WAHO levels. So I hope that when we move into discussion, I can also talk about the 17 indicators. Thank you very much. Thank you, Dr. Tano. Thank you for sharing Côte d'Ivoire's experience in integrating integration and the integration indicators that you have used. Thank you very much. I would also, again, like to ask our participants to note their questions in the chat, and we will take the time to respond to them as we are able. I would also like to remind you that there is an English interpretation that is available to you, and French interpretation will be available for any English speakers. Now I would like to invite Dr. Amadou for his presentation on training and capacitation. Thank you. Thank you very much. I am here to present the reference guide and frontline worker capacitation. I am based in Marrakech. Next slide.
My presentation will have 4 parts. First, background, then development process for the manual, then content of the manual, and finally achievements and lessons learned. For the background information, I would like to say first that we have a large proportion of women of childbearing age and in postpartum who do not use contraception. So we are trying to increase the use of family planning postpartum. The integration of services can help with increasing the universal coverage, particularly in terms of health and the health of mothers and children. As you remember, in Alma-Ata, the WHO had recommended that services should be integrated in terms of primary health care. Let's look at the state of play. There's the Inspire initiative with 9 countries. The goal here is to have an analysis of the situation of services. This was carried out by the IRSS in 2019, and this analysis showed large gaps in terms of integration. There was no guide, no reference, no training, but also a lack of skills and integration of services. To try to rectify the situation, we adopted a model for the integration of services, and several training models have been set up as part of this model in terms of nutrition, but also in terms of maternal, newborn, and child health. The process for creating this model was as followed. First, we had a very inclusive process of participation at the national level, but also regional level. We have had a lot of help from professionals, particularly gynecologists, pediatricians, and midwives. The documents that were used for developing this model were listed here in orange in the middle of the slide. We had the guidelines from the WHO, but also UNICEF, as you see in green at the bottom of the slide, and other institutions such as USAID and so on. Here you see the content. We have 14 chapters. First, we have the concept of the integration of services. This is chapter 1. So for this chapter 1 about the integration of services, we see that this model aims to fully integrate all aspects of healthcare for the mothers. 4 approaches have been highlighted in this model. First of all, prenatal, then delivery, then newborn, and finally postnatal. This integration model needs a reorganization of services. We need a single window where everything is offered by a single agent or several agents with a division of tasks. So we have a triage system within a single structure. We did not forget about the community side of it. So we have a whole package for the community, and we have prevention and professional care available for community members. Here you can see some general information about chapter 2. First of all, there's a reminder of the definition of the concept of reproductive health. We also have the definitions of family planning, essential maternal care, and so on. Then we have chapter 3. Chapter 3 is, first of all, a description of the content of chapter 3. It's the full package of maternal child care, also screening for cervical cancer, and all of these services can be offered at a single window. There's 4 sections in chapter 3, and each section is a particular approach or entry point. For example, section 1 is the delivery of integrated family planning care. as well as care for the pregnant woman, care for the newborn, and then we have section 2, that is the entry point about delivery. Here we are talking about the care given during delivery, but also the care to the newborn. Section 3 is about the provision of integrated service during postnatal care. Here we are talking about the care of the mother and the newborn in the postpartum period. Also management of complications, nutritional advice, and so on. Section 4 is the entry point on infant consultation and immunization. Here, it's about giving out vaccinations, but also taking care of the child, measuring weight, and so on. All of these packages have to be administered by a multidisciplinary agent or by several agents with a division of tasks. Here you can see the detail of the content of chapter 3, section 1. You can see everything that our model has under section 1, chapter 3, definition, goals, and objectives, the content of the package, preparation for delivery, so of general assessments, also a prognostic for the pregnancy and the delivery. We are still in section 1. Here you see details on the service package for section 1. We have the prevention of diseases such as malaria, HIV, also the early detection and treatment of existing diseases, so curative care, additionally to preventive care. And then we have screenings for breast cancer and precancerous cervical and breast lesions.
Toujours la suite, la section 1, le plan de préparation à
Still, for section 1, we have the plan for birth preparedness and also preparing the woman and the family for the delivery and preparing for any type of emergency. There's also a screening that is carried out for complications in women. First trimester bleeding, abortions, smaller pregnancies, ectopic pregnancies, and so on. Also complications in the second and third trimesters, placenta previa, preeclampsia, malaria, and so on. Now we are moving on to section 2. This is the delivery entry point. So first of all, there's a reminder of definitions and concepts on delivery. And then there's the care package, labor and delivery monitoring with the podogram, general obstetrical examination, then the use of the podogram itself.
section suite, section 2. Donc,
section 2. This is about essential care, immediate essential care for the mother and the child. So we are talking here about cleaning, episiotomy, repair if necessary, blood pressure, monitoring, and so on. Now, section 2. Here we're talking about essential care for the newborn. Sorry, my slides got mixed up. Let's go to section 3. Postnatal care. So we offer immediate postpartum follow-up care for the mother and the newborn. Here you see the detail of the content of this package. And now we're moving on to section 4. This is about monitoring the child's growth and psychomotor development. We also screen for malnutrition, and there is preventative care such as immunizations, supplementation in vitamin A, also screening for the usual childhood diseases, family planning. We give advice in the choice of contraception, and we screen for precancerous lesions, cervical and breast cancer. We are still in the chapter 3, appendix 1, promoting prevention, screening, and management of cervical cancer and breast cancer. So we do a follow-up of precancerous lesions. There is a consultation with a health agent. Also, telemedicine is available through WhatsApp, phone, or email, for example.
L'annexe 2, c'est la promotion de la santé.
Appendix 2. This is about the health promotion in integrated mother-child services. So this is already included in the service packages in the 4 entry points. These are care platforms that are helpful in promoting health. This is the way we talk to women about several topics and give advice on behaviors and habits that are good for the mother, the child, and the family.
Les différents thèmes qui sont discutés au niveau de...
The different themes that are discussed are topics of discussion and interviews. They are numerous and diversified, and the content has been adapted according to targets: pregnant women, women in labor, nursing mothers, etc. We look at some of the danger signs, preventive and promotional care, screening of precancerous cervical lesions at day 42 and beyond. Next slide. We also have in this module some cross-sectional chapters. So we have chapter 4, which is about prevention, infection prevention and control. We also look at biological liquid exposure accidents and biomedical waste management. In chapter 5, we looked at social and behavior change and communication. Then we have chapters 6, 7, and 8. 6 is about the quality of our HFP services. So this is the issue of quality of integrated services, quality of service delivery. Chapter 7 is the management of integrated services. We look at human resources management, equipment, health information, organization of services. When looking at, to make sure that integration is holistic, we look at everything that has to do with patient flow, task allocation, and care delivery. In Chapter 8, we do follow-up and evaluation. We look at the integrated service indicators. We have 10 indicators, and we also discuss data collection tools. Next slide. So accompanying documents, we have some learning worksheets. We have questionnaires to evaluate participants' knowledge, evaluation sheets, observation sheets, among others. Next slide. Next slide. So here we have our achievements and lessons learned. The integrated module have helped to build providers' capacity. So we have about 75 trained providers. Also, another thing that we have achieved is mentoring and post-training coaching. We need to reorganize services and ensure staffing standards for effective integration, and as a lesson that we have, as a takeaway, we know that we need to pool resources from different integrated training, mentoring, supervision in order to, and we also need to pool these resources for scaling up. Next slide. Here we have some of the results, and we have the immediate adoption of PPFP. And then we have the adoption of it during the immunization and vaccination consultations. So the uptake of PPFP in general is 4 in 10 women. And so we are seeing more women in the postpartum period who are using PPFP. So in our project, we are working to make sure that we can get to our goal of 5 in 10 women who accept family planning measures during the vaccination consultations. So here you can see the numbers from 2018 to 2021. So we're seeing a strong uptake among women of PPFP. Now, you may ask why this is important. We want to show our partners and our success, and we need to make sure that we can stay on the right path to make sure we can scale up this initiative to other departments and other regions. Thank you very much. This is the end of my presentation. Thank you very much, Dr. Amadou. You have stayed within your time limit, and I know that we are a little bit behind. We have only about 30 minutes left in our webinar. We have received many questions during the presentations. So, as planned, we are going to I will be the moderator of this. I will go ahead and pass the floor to Dr. Jhpiego, and then we will have time after that for our questions. Dr. Jhpiego has much experience, over 24 years in the field, and she has worked as a team leader of the WHO in many different countries. Currently, she will be speaking as the chair of our community of practice. And Jhpiego, if you are ready, you have 10 minutes for the presentation of the community of practice. which is what is bringing us all here to talk about integration. Thank you very much. And thank you, Yves, for giving me the floor. I will try to take less than 10 minutes in order to catch up on timing. So if Alison can move on to the next slide. So here is the outline for my presentation. We have the context, goals, objectives, the composition of our community of practice, its functioning, activities, opportunities, and then conclusions and projections for the future. You know, as others have already said, that there are strong global recommendations. Dr. WCARO already said that they are very much for person-centered integrated primary healthcare to reduce mortality, but also to improve people's well-being. We know that postpartum family planning interventions are high-impact practices. We know that with family planning, we would see a reduction of 82% of deaths due to unsafe abortions, and it would have very significant effects on women's lives in general. We have also observed that there is some verticalization, and there's also a low priority that has been given to integration and coordination, as Dr. Pierre said. So the challenge is to address low strategic priority given to high-quality integrated family planning, MNCH, and nutrition services, particularly during critical prenatal and postnatal periods, in order to reduce as much as possible missed opportunities and to increase the use of family planning methods and to improve services for mother and child health. Next slide, please. This is the context. So our goal or the purpose for our community of practice is to promote the integration, to promote the zero missed opportunity approach in order to optimize the use of our MNCH-N services and increase family planning method use. Our objectives, first, through the community of practice, to provide strategic support to the Francophone West African countries in order to accelerate integration of PPFP and also to improve the quality of practices and integrated services. And we are currently working on the other objective, which is to share best practices. We have existed since 2020. The community of practice is comprised of ministries of health, professional associations, like the Francophone African Midwives Association, and scholarly societies, which are represented today, civil society organizations, local governments. All of this is supported by a steering committee. Which is comprised of the WHO, the West African Health Organization, the African Society of the African Gyneco-Obstetric Society, FP 2030, and many others. We have a rules of procedure and operational action plan of the steering committee, and we work to accelerate the integration of PPFP through coordinated actions, technical assistance and learning, evidence sharing, and experience sharing, which is some of what we saw today from Côte d'Ivoire and Niger. Next slide. So what is the model, the proposed model for integration? And how is it organized? We have a regional platform that is the community of practice on integration. We have our steering committee that is chaired by the WHO. We also have country focal points, which are members of technical working groups. on integration, and we have stakeholders, which include government decision makers and implementation partners. So you see that we have close collaboration in order to ensure our success. Next. We have also organized many activities, and we know that we have many opportunities before us. We have provided technical assistance and capacity building as needed. This can include country visits, webinars, and we have even created an experience sharing platform. And you will find resources on this platform, including technical resources and reports from meetings that we had in 2021 and 2022. But also we have a joint planning in order to pool our resources and means of the steering committee and the members. Next. So we support and accompany Francophone West African governments in updating their national FP or MNCH plans, taking into account integrated PPFP. We support countries to identify priorities and develop a plan when necessary to accelerate and scale up PPFP integrated with RMNCH and nutrition. We have received a silver award at the 3rd edition of the ECOWAS Best Practices in Health Forum in November of 2021 in Praia. Next. So we're still looking at different activities and opportunities. We were able to support various studies and publications of papers on the maintenance of RMNCH and nutrition services during the COVID-19 pandemic in Francophone West Africa. This article is available on the platform, and we have also successfully advocated to partners at the annual meeting in Lomé in May 2022, where we were able to advocate for the creation of a fund to support scaling up to the national level in different countries. So this was a great success that happened in Lomé in May 2022. Next slide, please. We continue to be moving and traveling. We attended the Grand Challenge meeting in Brussels to meet with partners. We did advocacy for resource mobilization in countries in order to include PPFP in RMNCH and services. We also participated in roundtables, and we have them planned in different countries in order to encourage continued mobilization of partners and resources. We also want to expand the community of practice and country committees to include other partners in the field. At the end of 2022, we already had a new partner, and this has motivated us quite a bit, and it's shown us that we can continue to enlarge our partnership, and to do that, we can better optimize and leverage our resources and efforts. Next.
To conclude, what we need is the leadership from the countries. This is a key factor for success in sustainability. We have a synergy. We want to promote it more, and we hope to be able to continue to mobilize more and more partners, particularly from the private sector. We all want to move forward very quickly to scale up and to move towards universal healthcare, and of course, to also succeed in terms of the SDGs. We only have 8 years left. So I am now available to answer your questions. Thank you. We are with you. We are supporting you. Thank you. Thank you, Trifoni. I think it's an excellent initiative that is currently underway in West Africa, where several partners are joining forces to move forward on postpartum family planning. And so thank you so much for this initiative that is seems to be well underway. We are done with the 4 presentations, and so I would like to give the floor to Professor Sepu to moderate the questions and answers session. And we have 15 minutes for this session, so that then Marguerite will have the last word. Thank you so much, Yves. We listened very carefully to all 4 presentations, and I have to say it was very interesting to hear from Niger and Côte d'Ivoire. We would like now to give the floor to participants. We do not have a lot of time for our discussion, but we will take a few first questions so that our presenters and experts will be able to answer those questions. Professor Sepu, I think that it will be useful to look at the chat. We have 247 people online, but we have questions in the chat. I think it's going to be hard to manage all of the questions. So to make things easier, I already identified a few questions, and I think we could give them the floor, or we could read their questions, and those who will not have their questions answered, I think we can do that later on, if that's okay with you. Perfect. Thank you, Yves, for having done this work, and I think that's the way we should proceed. I give you back the floor, Yves. Okay, thank you, Professor Sepu. I identified 4 questions that I think are very useful, and I will start with the first one.
One-stop centers for providing integrated care at primary health care level. This is Dr. Prita Visma from Pathfinder International. Ça, c'est la première question. Je voudrais mieux comprendre, connaître, entendre sur...
So this is the first question. The question is about the one-stop shop for integrated healthcare. Do I answer the questions one by one, or do I wait for all of them? Okay, second question.
Challenges of technical implementation at the primary care level with regard to the low technical capability at that level. C'est bon? Troisième question.
Oui. Third question. Thank you, doctor, for this presentation. I work in a health center. Digitalization of the patient's records is very important. I would like to know if you have a software for digitalization. And fourth question, in the single window, are there several services, several teams, or is it a multidisciplinary team? So here we are with the 4 questions, and you now have a few minutes to answer.
Integration indicators and cost effectiveness.
Et je crois qu'il y a une question sur l'efficacité des coûts et les indicateurs. Dit Monsieur Cario.
Pierre Claver, vous avez la parole pour
Okay, Pierre Claver, Carrillo, you have the floor to answer to the 4 questions. Donc pour so for the one-stop shop or the single window, what I wanted to say is that it is a single point of service where we are able to deliver the majority of services that are needed. For example, what the colleague from Niger presented showed how we can offer reproductive health care in a single window at a single point. And I think that if the person looks at the presentation, they'll be able to find the answers they are looking for. Then there was a question about how
with low technical capacity. Ça, c'est vraiment une question très complexe de.
So this is a very complex question about the mitigation. In my experience, primary health care is carried out, has to be carried out at several levels with a trained staff, and they have to be enough providers to cover the needs. And these services have to be rendered at the right time when they are needed. So it is absolutely essential to have human resources that is well trained and knowledgeable. But they also have to be multidisciplinary because they will carry out several tasks. They need to have a wide range of skills. So human resources is key, but they have to be trained properly. This is what I can tell you about this. Now, about the question of on digitalization of patients' records, I do not know a specific software, but I think that our experts probably can help. There was a program called Electronic Medical Records at the WHO, and that program has been used in training programs. I am not an expert, so I cannot direct you to a specific software, but I think that our colleagues, experts in the field, will be able to answer your question. 4th question, I'm not sure I understood it properly. If you can repeat. If you can repeat the 4th question, please. Yes, so the question is, are there several teams or just one multidisciplinary team in the single window? So there are several models. You can have a single window with different people and they all have their own specialty, or you can have a multidisciplinary team. So it depends on what you can do and what you want. They can have complementary skills. Okay, great. Now, do we have 4 questions for Dr. Yoon? Dr. Yu, here are your 4 questions. I know that there are more than 4, but I think we only have time for 4. We can answer the others later.
How you are measuring integration. It will be great to hear more about integration indicators you have used. Donc, les gens voudraient savoir davantage sur l'utilisation pratique.
So the question is about the practical use of indicators. And they are asking if the 17 indicators will be shared in English also. third question, what is being done to ensure the quality of data? And fourth question, which is linked to the third one, is how do we assess the quality of data? Since you update DHS every 2 years, how do you ensure the quality of data? Dr. Yu, you have the floor to answer the questions.
Dr. Yu, vous avez la parole pour répondre aux 4 questions.
Bon, d'abord, il faudrait... Non, j'ai partagé les indicateurs composites, là.
3 minutes.
Hein, indicateurs composites, regardez dans la diapo.
I shared the composite indicators on the slide. First, we have the proportion of newborns with a low weight and also the proportion of mothers who have adopted a contraception method, a modern contraception method, for example, and have received advice in terms of family planning. So as you see, we need to better orient our actions on the basis of these indicators. We've been able to scale up our strategy in Côte d'Ivoire. We divided Côte d'Ivoire in 10 hubs, and in these hubs, we are carrying out everything that we've learned from the indicators. The proportion of low weight premature newborns for whose mother have adopted modern contraception methods. So we looked at this indicator. And we also looked at the community health agents. These agents go to the homes of the mothers to see how things are going, and we are looking at the proportion of women. The interpreter cannot hear the speaker. The proportion of pregnant women who have received advice on family planning. This is another indicator. So all of these data allow us to better integrate care. To go back to the update and the question on the quality of data, in what I can tell you in 1 minute, what I would like to say is that the question is not correct because the update is being made each month. The interpreter cannot hear the speaker again. It is the review of the indicators that is being made every 3 years. So here's the situation. And for the quality of data? So the question on quality of data, what I can say is that we have a matrix for the consistency of data. And what we do is that we meet regularly. We analyze the data. And if we find out it is not consistent, what we do is that we try to rectify this and ensure data is consistent. But of course, we can have all the data we want, but if it's not consistent, it's no use.
Thank you. And now I would like to give the floor to Yves for the next 4 questions. And I think Blami Dao, you have your hand raised. Do you have something to add? Thank you very much. Chair, I have a question about scaling up. This initiative started, I believe, in 2019. And what are we doing now to make sure that we are continuing to move towards scaling up? Thank you very much. You have a response? I didn't really hear the question. Can you repeat the question? Do you have an answer? The scaling up of what? I'm not sure I understood. The scaling up of integration. Yes, that's a very good question. I believe that scaling up should be looked at in a country context. And we should look at the implementation of integrated care, integrated people-centered care. And we need to have pilot projects in different healthcare facilities before, and then we can move into scaling up. Personally, I do not have any experience with implementation in a specific country, but generally, or I believe that it starts with integrated care for pregnant women, newborns, children. And I think that integration is much more advanced in reproductive and maternal health questions than in other healthcare fields. That's what I think is happening at this point in time. Thank you very much, Pierre Claver. We have Dr. Marguerite, who has also raised her hand. But if we could move to the next questions that Yves is going to ask. Dr. Yves? Yes, thank you very much. Thank you, Professor. Now we have questions for Dr. Amadou. So we have a participant from Burundi who would like to have the document that you developed. And we have another participant who would also like an electronic copy of the document. So those are the first questions. The second question, Dr. Amadou, in your experience,
outcomes of training on integration at community level, and if there is a role of integrated trainers to optimize training resourcing. Thank you. Troisième question.
Traduction.
Traduction.
Oui.
Les gens voudraient savoir s'il y a eu des
So they wanted to know if you had any results with regards to training on integration at a community level. Yes. Okay, I've noted that. And if there is a role for integration and resource optimization. The third question is we commend the efforts, the implementation efforts in Niger. Can you talk to us a little bit about the efforts to ensure continued availability of products and what you have done for nutrition, which represents a significant challenge in many different contexts? There is also a question that is a request for electronic copies of the documents. We also had a question on the role and the integration of midwives in integrated service delivery in Niger. We also have a question from Hortense Achoumi, who first wanted an electronic copy of the documents, but also wanted to know if In the community component, the strategy that was announced, how has this strategy been advanced and how has it been implemented in integration? So those are the questions for Dr. Amadou. Thank you very much, Chair. So I will start with the last question about strategy. And the strategy that we used at the community level to promote integration. At the community level, there are several levels of intervention. So we had stakeholders who were working together at the community level who were there to promote community health. So we worked with them on this advanced strategy. At each health center, there are health workers in the communities. We also develop strategies in order to increase integration at the community level, and we use this in different villages. In terms of as a health provider, we had trainers and we had mentors. And we used the most experienced as a trainer to build capacity and to train skills of different health workers. We also used mentors who worked in monitoring and supervision of different activities. So that's some information about the training that we used in order to work on skill building. Now, with questions as regard to the integrated trainers. First, when looking at skill building, we worked with our healthcare workers. And then when we had trained workers, we had follow-up and evaluation with these providers. We also provided mentoring for them. The trainers were also able to work on the ground for skills building with our participants. And for the last question, there was a question about results at the community level. I think that at the community level,
au niveau communautaire, c'est surtout le nombre d'agents que nous avons eu à former.
What is most important is the number of health workers that we were able to train. So we had about 55 in family planning. We were also able to raise awareness among women about using family planning methods and services. We were also able to raise awareness about sexual and reproductive health in general. And I know that we have others who are here who could perhaps contribute their experience. Dr. Amadou, you have responded to the questions. Thank you very much. I know that we will not be able to respond to all of the questions that have been asked. We just don't have enough time, but we will look at these questions and we will respond, we will answer them as possible. Thank you very much. Professor, do we have a bit of time to go over a few more questions? We have already gone over time, and so I think that we need to move on to the discussion conclusions. So we will give the floor to Dr. Marguerite. We know that we will be gathering all of the questions, and we're going to answer them and send our responses to the participants along with the slides that have been used today. Thank you very much, Professor. And now, Marguerite, you were originally given 10 minutes, but if you could perhaps make it a bit quicker, that would be excellent. Thank you. Thank you very much. Dr. Yves, I think that we can cover these conclusions in 5 minutes. So in this meeting, we have addressed very important issues that are of particular importance in our region. We're looking at postpartum family planning and how we can integrate it into reproductive, maternal, newborn, and child health in order to improve the quality of primary healthcare for mothers and children. This is important in our context, and particularly in a context of insecurity, which makes everything more fragile. I would like to thank our partners who were able to put issues of maternal and child mortality at the heart of our work. We are also looking at indicators that we will be analyzing from now until 2030. We were able to understand the operational challenges and difficulties. We saw examples that were presented, and we understood the actions that need to be taken in order to build the foundation for operationalization and institutionalization. We also understood the need to collect data and analyze this data in order to understand the level of integration that we have achieved in different health districts. We have also learned about the importance of innovation and integration in order to respond to community needs. Community level care is essential when we're looking at the establishment of universal health coverage. So to respond to a question that was asked about the community level and the scaling up to a national level with integration, there are many partners, including the Gates Foundation, the Ouagadougou Partnership, and many others. They are creating a pooling fund in order to support countries in this scaling up process. So this fund is going to help countries to scale up integration. We have seen results that were shared by Niger, where they have quadrupled women's uptake of family planning methods. When family planning is integrated into each consultation and each contact point with women. We also talked about how partners can better support integration. We talked about the different techniques in the countries, and partners can participate in these techniques, or they can contribute to the community of practice. We have the president, Dr. Trifoni, who presented the community of practice, and she was able to look at all of the interventions in the field, as well as the provision of technical assistance in order to operationalize this approach. So we can ensure a lasting integration of PPFP. and also access to information on different platforms. These platforms exist in partnership with IBP and Knowledge SUCCESS, and so we thank them for their partnership. We also have online platforms that exist for knowledge sharing, experience sharing, and sharing of best practices. So you will find best practices there. We also encourage collaboration and experience and knowledge sharing. And we all know that electronic information is very important. This is a way that we can share our experiences. This platform allows us to build on lessons that others have already learned, build on experiences that others have already implemented. So thank you so much. I would like to thank all of the presenters here today. Thank you to all of our participants. And we're looking forward to our 2030 meeting with a lot of hope. And so I would like to leave you with this, how do we ensure integration of our health systems in order to have better performances and provide better quality care? Thank you very much.
Thank you so much, Marguerite. Thank you for this summary of our talk today. I think you summarized very well everything we talked about in this hour and a half. So I would like to now thank everybody who made this meeting possible, everybody who was connected. Thank you to all the participants. Thank you all for your interest and your questions. Thank you to the panelists. As we can see, we are now in a process that is well underway, and I think that everything is looking good. So thank you so much. And I think we will probably reach our goal of improving the quality care we can give to the mothers and the child. So thank you so much for your commitment. And the questions that have not been answered will be sent, and we will send the answers back to you, to those who answered, to ask the questions. Thank you so much. Thank you, everyone. Thank you, Yves. Thank you for this very efficient webinar. I think we had a lot of participation. Unfortunately, we did not have enough time to answer all the questions, but we will try to do so. Thank you so much.